Okay, we can go to the first slide. So, what is coordinated specialty care? This is a term coined by the NIMH in 2015, and it describes really a specialty team-based model of care where several different treatment elements are integrated and combined and delivered uh, and adapted for young people who are not just young in age, but also are new to the mental health care system and their family members. So, if you look at the list of interventions in the outer ring, I think most of you will realize, especially those of you who work in the public mental health system, that these are not experimental treatments. These are treatments that have been used and are available to many individuals. Perhaps less so in the private system, where often some of these services, especially family support and education or supported employment, are either not or very poorly reimbursed. So they're variably available, but they are available. I think what's special about CSC is that the clinicians are dedicated to the care of new onset psychosis patients and their families. And over time, as with many other things, doing it again and again, a lot of practice and seeing lots of cases builds a lot of expertise in engaging young people, retaining them in care, and improving outcomes. And so I think there's a slide on this further along, but um, uh, there's good evidence from trials that have been done in several countries now around the world that when you coordinate care within a specialty team, it tends to beat the outcomes of other kinds of services that might have the same elements of care but are not structured into a specialty care model. Um, this slide is to make the point that aside from coordinating care and, in other words, improving the quality of the care, it's very important to also reduce delays to access. So early detection, which is something that STEP delivers and is now disseminating across the state, is an effort to shorten the so-called duration of untreated psychosis, the time from psychosis onset to the beginning of treatment. So that journey needs to be short. It also needs to be one, ideally, that's not aversive, that minimizes the chances for unpleasant interactions with involuntary treatments or unpleasant interactions with the police, rather than more supportive interactions with the police that when people can be brought into care. So our care pathway in the state that we're are rolling out includes both these elements that are essential for good, optimal early intervention services. Next slide. So I think I mentioned this already. For those who want the references, we're happy to provide them. There have now been randomized controlled trials done in several countries. The STEP randomized trial was the first in the US. And the RAISE study was published shortly after that essentially replicated the finding that when you structure care in this way, you improve a range of outcomes: hospitalization, quality of life, getting back to school or work, things that matter to individuals, but also things that matter in terms of healthcare cost are positively impacted by these services. The slide sort of just describes what is now a 20 plus year journey from the first trials that were done in the UK, the Leo study, and in Denmark, that actually used ACT level services, clinician to patient ratios of 1 to 10, 1 to 12. These were very intensively resourced services that were the first to demonstrate that they dramatically improved outcomes compared to usual care. The US studies, STEP and RAISE, use office-based interventions. ACT services are not widely available in the US, but we built this on public sector, community-based clinics where most care is provided in the clinic and not out in the community. And we're also able to show similar improvements in outcome. The evidence base is now maturing. So some countries like the UK and Denmark are ahead in terms of expanding access to these early intervention services across the country. The US is on this journey. It's maybe 5 or 6 years in. There are clearly not enough of these services across the US. Some states are ahead of others. And so you'll be hearing more about our efforts in Connecticut, and especially through our newsletter, we are keeping people up to date on progress. Um, but the good news is Connecticut has had an important role to play in developing the international evidence base. And in the US, we are a state that's leading in terms of early detection, quick access to services through the use of the kinds of media messaging and outreach that Laura had mentioned. Next slide. So, this is just to highlight the fact that a lot of the work we do is coordination, and this is an activity that not just in psychiatric care, but in primary care and medical care in the US is tremendously undervalued in terms of reimbursement, but is a huge value add in terms of the experience of care for patients and families, and also for their outcomes. And so we spend a lot of time investing in talking with patients, but also their family and friends, whoever is important to them in their lives, um, because we know, and the evidence clearly points to this, is that having a, a group around you that is able to help you when you're having signs of relapse, who's able to support you through your healthcare pathways, is vital to making effective use of treatment and getting on with your goals in life. We, as Laura had already mentioned, we work very closely with community stakeholders to help improve pathways to care, but equally encouraging these community stakeholders to also play a role in supporting individuals when they are seeking to return to school or college or work, being sort of in their corner when they are advocating for themselves as they return to life in the community, which in the end is the goal for this kind of treatment. The idea, of course, is to make ourselves less and less important in a person's life, which is a measure of success in terms of clinical treatment, and to have more and more of their own goals drive their daily activities. So there's more to say here again, and I'm sure we'll get into it in our echo sessions, but this is a vital part of what coordinated specialty care provides. Next slide. So this phrase of phase specific is important to keep in mind. Young people who are early in the course of schizophrenia will often go through these recurrent cycles of engaging with care, getting better, leaving care, needing to re-engage with care, getting better, leaving care. Now, we would wish that they didn't have to go through these circles and went straight from engagement, treatment, recovery, and on with their lives. And some, in fact, do. But for many, it's part of the process of learning to take care of their illness that they be allowed sometimes the chance to stumble and not be punished for it by being disqualified from care when they come back after having stopped their medications or left treatment and wanting to return. And the point of thinking about this as phase specific is to understand that there are phases of care in which a coordinated specialty care service can engage, and they may have to engage with these phases repeatedly with a person, but over time, this increases the chances of getting to a stable recovery phase. And there are distinct things we can do at each of these phases. And we shouldn't be discouraged if we have to return to an earlier phase in order to move someone further along this pathway to recovery. Next slide.